Hi everybody. Today let's do something different. I'm going to discuss an X-ray and MRI that belongs to the same patient, and I will compare and contrast the features which are in the X-ray versus the MRI. The history goes like this to that patient. She's a 28-year-old female. She works in front of the computers for the past so many years, and she used to get episodic neck pain on and off for every 2 to 3 months. She'll be getting a neck catch, and this is happening for the past 5 years. Of late, the pain is going to the left side of the shoulder, scapula, and to the arm, and sometimes tingling to the left fingers. She has the desire to constantly crack her necks, and she'll be constantly moving her shoulder blades in order to loosen it up. She went to chiropractic treatment and a few physiotherapy sessions earlier, but the symptoms still persist. This is a pain chart. You could see the pain is in the left side of the shoulder blade, and sometimes it goes up to the head, and the pain nowadays is going to the left side of the arm, forearm, and distant fingers. The X-ray is taken in the lateral view. You could see here the X-ray of this patient, the Woodentide process here, which is belonging to C2 cervical spine. From there, if we calculate, we can goes to C3, C4, C5, C6, and C7 vertebrae. The longest spinous process is belonging to C7 vertebra. In this X-ray, what else you can see? Nothing greatly abnormal. The curve is reasonably decent. It's not really a straightening of the curvature. The disc space is reasonably maintained, except that maybe some small disc space reduction here and mild haziness over here that tells that early arthritic changes. Apart from that, if you show this X-ray to any doctor, they'll say, okay, this is a good-looking X-ray. Maybe it could be a normal muscle catch. You keep strengthening the muscles and stretching the muscles, maintain the posture. That's all they say, and then they medicate this patient and then send them off because X-ray is revealing nothing. If you see the MRI of the same patient, it's completely different. You see there is a kyphotic curvature. It's not even a straightening of the curvature. It is an anterior kyphotic curvature, which is causing disc space reduction in this C2 is this Woodentide process is C2. This is C3, C4, C5, C6. Between C5 and C6, the disc is bulging and compressing the anterior thecal sac over here. So what you could see in this MRI is that there is a curvature change. There is an anterior curvature change. There is a mild disc bulge which is compressing the thecal sac. And mild degeneration is happening over the 1 or 2 levels of cervical spine. This line indicates the line of gravity that is passing through the cervical spine. Normally, the line of gravity, when you are drawing a line along the Woodentide process, it should go and intersect somewhere here. Over the body of C7 vertebra. But this line, because there's an anterior curvature, the line of gravity itself is shifted anteriorly. Now, what is the problem with that? Once the line of gravity is shifted anteriorly, there will be a excessive gravitational torque anteriorly that increases the flexion momentum. Okay, so that will be countered by the muscles over here. So there will be a constant workload that will be onto this muscle that has to keep the neck upright. If not, the gravitational torque will try to cause more and more flexion that will be countered by this muscle, and the net result is excessive joint compression force in the cervical spine. So when there's an excessive joint compression force in the cervical spine, intervertebral joints, then automatically the disc will start to degenerate, or it will start to lose its water content. And as the water content is lost in this disc, it loses integrity and the strength. You know, when the car tire is with full air, the car is having good stability. When the car tire will be having less air or no air, then the car will be wobbling. Something similar to this, when the disc has good water content, it will be staying strong and stable. When the disc is losing its water content, it becomes shabby and it tends to move here and there. And because there is a anterior compression force happening in the cervical vertebra, the disc is like a jelly material. So when you compress in the front, it will squeeze in the back. And that's the reason why most of the disc herniations and the disc bulges are all happening posteriorly. Hardly or seldom you will see anterior disc bulges. Okay, so this posterior disc bulge, if it goes back, it doesn't keep calm. You know, it just starts disturbing the dural sheath. It disturbs the nerve, and that nerve will produce pain in the neck or in the shoulders, or it can go anywhere. So this is the features that I want to discuss in the lateral view or the sagittal view of the MRI. This is the full sequence of this MRI. You can see the full spine view, mid sagittal section, and these are all the parasagittal section from left to right. The axial view, you see, I have picked up only the relevant views in the axial section. You see here the line this line is slicing the cervical spine between C5 and C6, and C5 C6 is here. So the transverse view what you see here is the corresponding view of what is sliced here. So you are seeing the disc level cut C5 C6, and if you see this is the disc, this is the foramen transversorium over here where the vertebral artery is passing through. This is the spinal canal. The white color stuff what you see is the cerebrospinal fluid, and inside you have the big spinal cord here. Okay, and here is the facet joint. This is the canal for the nerve to pass exit out of the spinal canal. This is otherwise called as intervertebral foramen, through which the nerves will exit out of the spinal canal. So if you see here, there is a bulging of the annular fibrosis, which is disturbing the anterior thecal sac. What is normal? You go to the lower level. This is corresponding to C5, C6, C7. C6, C7, the annular fibrosis is maintaining its reasonable distance between the anterior thecal sac. So you see the nice amount of CSF fluid is present here, whereas if you see here, the CSF fluid is compromised because the bulge is in such a way that it is moving the CSF away from that particular spot. Plus, you see the canal diameter, the intervertebral foramen canal diameter is pretty big compared to this here. Okay, so in MRI, this is left side, this is right side. Okay, so there's a posterolateral annular bulge which is compromising the anterior thecal sac and the exiting nerve root, which would be one of the justifiable reason for the patient who is having left-sided pain, which is going till the fingers. The moment the pain is radiating in nature, by and large, it would be of nerve compression. All right. So what we see in the MRI is correlating with the patient's symptoms. Here is a comparison between X-ray and MRI. X-ray is always weight bearing because when you're taking the cervical X-ray, patient is standing, isn't it? So the weight of the head is passing through the spine, so that is called as weight bearing cervical spine X-ray. Whereas MRI, all the MRIs of the cervical spine are taken in supine lying. So when you are lying supine, the neck is not taking any weight, so we call it as a non-weight bearing. Plus in X-ray, the head is reasonably extended. You see here that the patient has attempted to extend the atlanto-occipital joint. This is a standard position for cervical X-ray. But when you are doing the extension at the cervical spine, whatever curve that you may be having, that may be altered with the extension attempt. Okay. Whereas in MRI, you are not making any attempt to extend the spine, so it is showing whatever you have as a curve. All right. Plus, the X-ray is showing only two pictures and two views. One is AP view and the lateral view. Unless until the orthopedician or the physio is asking for any other additional views, the standard views are AP view and lateral view. What you see here is the lateral view. All right. The MRI will be having multiple slices. So you can have a transverse view, you can have a sagittal view, you can have a coronal view, and for each view, you will have at least 6 to 7 slices. So you'll be ending up looking the spine into various dimensions. That's why MRI is always 3-dimensional and X-ray is 2-dimensional. So if it is 3-dimensional, you will get more information compared to 2-dimensional pictures. So X-ray is still good. It's good to identify the bone alignment, the space between two bone, the intervertebral joint space reduction can be seen. Early orthotic changes can be picked up. In case of fracture, dislocation, anterolisthesis, retrolisthesis, calcification, fusion, these are all can be picked up from the X-ray. But when it comes to the soft tissues, MRI has always an potential edge. If you want to see the disc bulge, disc degeneration, disc herniations, facet joint arthropathies, canal stenosis. So these are the other soft tissue problem that can be easily picked up in the MRI. So MRI and X-ray is always a good forms of investigation, but in your clinical practice, no, you have to go by your physical examination, because physical examination is the king for all types of mechanical pain. If there's a traumatic pain, then you need to straight away refer them for X-ray or MRI if you think that the trauma is quite big enough. In my clinical practice, I have seen a bad looking X-ray and the MRI, the patient had very less or no symptoms, whereas a good looking MRI, textbook MRI, the patient will be having a severe symptom. You need to get the history, the physical examination, and then the investigations all put together. Probably you can make a better diagnosis. MRI has a potential edge than the X-ray, especially for the disc or nerve-related pathology. But as a physio, as our profession is evolving, as our patients are demanding more from us, I think the physios must start learning X-ray and MRI interpretation so that they'll have a better mileage in their clinic, and the patient will also start have building confidence on you if you start reading MRI and X-ray. I hope this video is of some help to you. I'll catch you up in one more video. Thank you for listening.